Welcome to today's webinar, Take Cancer Survivorship Care Plans and Late Effects. My name is Sara Tirani, and I'm the Program Coordinator for Triage Cancer. I'll be moderating today's webinar. Now, before we dive into today's topic, I just need to go over some housekeeping. All callers are muted for the duration of the webinar. If you have any questions or technical problems, please type them in the chat box. This webinar is being recorded and will be available for viewing by the end of the week on our website, triagecancer.org. At the end of the webinar, you'll be redirected to the survey. Please take a few moments to fill it out and let us know what you thought of today's webinar. For those of you who aren't aware, Triage Cancer is a national nonprofit organization that provides cancer survivorship education on topics that arise from the point of diagnosis throughout life. And we provide this education in a few different ways. First, we host a Speakers Bureau of experts in all types of cancer survivorship issues, available to organizations putting on an educational event. You can read our speaker bios and request a speaker on our website. We not only participate in events all over the country, but we also host our own educational events for patients, survivors, caregivers, advocates, and healthcare professionals. We host a series of Triage Cancer conferences on a variety of cancer survivorship topics. This year's events will be held in Ypsilanti, Michigan, Reno, Nevada, and Lewiston, Maine. Travel assistance is available for patients and survivors to attend these events. You can find that information on our website. And as you know, we host a monthly webinar series. The next one will be on April 11th, and it's entitled Caregivers, Learn to Listen to Yourself and Cultivate Self-Care Habits. In partnership with Cancer and Careers, we offer free one-day training for healthcare professionals called Navigating Cancer, Work, and Insurance. For more information, visit our website. We also offer the Insurance and Finance Intensive. This is a comprehensive certificate program for oncology healthcare professionals and advocates on health and disability insurances and finances. We are hosting our next intensive on May 11th in Rancho Mirage, California. Registration is open on our website for that. If you're interested in having an intensive in your area, please email us at info@triagecancer.org. In addition to our events, we offer a number of online educational materials and resources. Our quick guides are designed to be a snapshot on a particular topic. They cover areas such as health insurance, employment, clinical trials, financial topics, estate planning, and legal assistance. We also have state-specific resources on our site, including topics you'll hear about today. And because where you live can impact the protections you have access to, we have charts of state laws on employment, disability, and health insurance-related issues. We also provide educational animated videos on cancer survivorship topics. We have this one on health insurance basics with key information you need to know about your health insurance plan, especially to minimize your out-of-pocket costs. These videos are available in English with Spanish subtitles. We plan to release a new video on how to pick a health insurance plan later this month, and there are more to come after that. Cancerfinances.org is a site that we host in partnership with the SAM Fund that provides practical information on topics that can impact your finances. We also provide contact information for financial assistance resources. We just released a new module on education, which covers education rights in school, accessing accommodations, and dealing with student loans. Our educational blog also provides great information about cancer survivorship topics. And because things are constantly changing in the cancer community, this is how we share late-breaking news. We also have a monthly newsletter that you can sign up for on our website. Now, with no further ado, I am delighted to introduce you to today's speaker, Joanna Morales and Dr. Saro Armenian. Joanna Morales is a cancer rights attorney, author, speaker, and the CEO of Triage Cancer. Dr. Saro Armenian is a pediatric hematologist-oncologist with experience in pediatric cancer, epidemiology, and cancer survivorship. He's an associate professor in the Department of Pediatrics and Population Sciences and is the director of the Division of Outcome Research at the City of Hope. And
Thanks, Sarah. So before I get started, I did want to say that we are very grateful today for the support of the California Department of Public Health's Comprehensive Cancer Control Program and the California Dialogue on Cancer. The California Dialogue on Cancer is also referred to as CDOC, and CDOC is our state cancer coalition that you can all join if you are interested in. Now, every state has a comprehensive cancer control program that is funded by the CDC, and in every state, the Comp Cancer program, it's possible that they also have a stakeholder coalition. So if you are in a different state besides California, you can actually go to our website at triagecancer.org and visit the state resources page, and you can find not only your state's comprehensive cancer control plan, but the program information and the contact information for the coalition. Now, one of the California Dialogue on Cancer's projects is the drafting of the state's comprehensive cancer control plan. And one of the initiatives in the cancer control plan focuses on treatment and survivorship and increasing the usage of cancer survivorship care plans. So to get us started today, I just want to briefly talk about what a cancer survivorship care plan is before I turn it over to Dr. Armenian. Now, because your need for care doesn't end with your last day of cancer treatment, a cancer survivorship care plan can be very valuable because it gives you and your healthcare providers a guide to monitor and manage your ongoing care, and can also help you navigate any additional post-cancer care needs that you might have. Now, an effective cancer survivorship care plan is typically a written document that includes a summary of your treatment, recommendations for follow-up care, and other relevant information to help you anticipate and address the long-term and late-term physical, psychosocial, practical, and financial effects of cancer treatment. Now, another goal of a cancer survivorship care plan is to assist in the coordination and transition of your care from your oncology healthcare team to your primary care providers as your oncology treatment is completed. And ultimately, once you get a cancer survivorship care plan, it's something that you should provide a copy of to your primary care providers. Now, you typically receive a cancer survivorship care plan at the end of your treatment. However, there are some patients who never stop receiving treatment. So some providers will also give a version of a care plan to their patients with advanced cancer who are receiving long-term treatment. Now, every cancer survivorship care plan should include medical and non-medical information to be the most effective in assisting you in navigating through the variety of cancer survivorship issues that may come up. So the parts of an effective cancer survivorship care plan include a treatment summary, which details your cancer diagnosis, such as the date that you were diagnosed, the type of cancer that you have, the stage, any treatments that you've received, such as chemotherapy, radiation, surgery. It should also list the names and contact information of your healthcare providers and treatment facilities. The second part is a follow-up care plan, which includes specific recommendations for your ongoing care and includes things like possible signs of recurrence and ways to identify and manage long-term and late-term side effects. It also gives you information on healthy living, such as smoking cessation and alcohol restrictions, nutrition and dietary modifications, regular physical activity, and weight-bearing exercise recommendations, and immunizations. A cancer survivorship care plan also includes topics related to psychosocial care and deals with many of the practical issues related to insurance, employment, and finances, as well as many others, but then it also provides resources and referrals to actually get help with those psychosocial and practical issues. Now, the long-term goal is for every patient to receive a care plan, but not every cancer center or oncologist's office actually offers cancer survivorship care plans. So you can visit a cancer survivorship clinic to get help with the care plan, even though you haven't received care at that cancer survivorship clinic. So you can talk with your healthcare team about where you might find a healthcare facility locally that offers cancer survivorship care plans. But if your healthcare team isn't aware of a local cancer survivorship clinic, you can actually check to see if there's one in your area using OncoLink's online search tool. So to look up cancer survivorship clinics in your area, you can visit oncolink.org/survivor/clinics. If there isn't a clinic in your area, there are a few cancer survivorship care plan templates that you can use to develop a plan for yourself using your medical records. But as medical records are often hard to read, you may actually want to talk to a member of your healthcare team for help completing your survivorship care plan. So these are just some examples of plans that you can complete. There's the OncoLife Survivorship Care Plan, there's What's Next, Life After Cancer, and there's Journey Forward. Triage Cancer, in partnership with the California Dialogue on Cancer, actually created a toolkit for healthcare professionals to help support facilities that were looking at implementing cancer survivorship care plans or cancer survivorship programs for their patients. This is available on our website, and while the toolkit is a few years old now and there have been some updates to some guidelines, it can still be a useful resource for healthcare professionals who are looking for resources related to cancer survivorship care planning. We also developed fact sheets for patients about care plans, which are actually available in a variety of different languages. And we have a short video for patients on care plans to introduce them to the topic. And these resources are all available on our website at triagecancer.org. So now I will turn it over to Dr. Armenian, who will give us a more in-depth look at cancer survivorship.
Okay, so can you hear me okay? So thank you very much for the introduction. So it was mentioned earlier, I'm a pediatric oncologist, but I'm also an epidemiologist. That means I study the health of individuals, large populations. A lot of the work that we do isn't limited to survivors of childhood cancer, but what I'll be talking about today is really relevant to all cancer survivors. And it's especially encouraging that much of some of the material that I'll be covering today was already covered. So it'll be a refresher toward the end. So I'm trying to advance. Okay, perfect. I'm gonna. Okay. All right. So just a sort of a snapshot about where we were 20 years ago and where we are today. You know, you could safely say that we're in the midst of a cancer treatment revolution. In the past, when someone was diagnosed with a cancer, they were primarily diagnosed based on what we saw under the microscope or the size of the tumor itself. There were 200 fewer treatment options available just 20 years ago than there are today, and that number is rapidly increasing. There were really three basic treatment modalities. They included surgery, chemotherapy, and radiation, but we know that there have been dramatic improvements in treatment options, including immunotherapy and bone marrow transplantation, that have really changed the lives of many of our patients. And then at the time, there was a very limited concept of what supportive care is, what the importance of supportive care was to the delivery of cancer care. So when we think about progress, we think about progress over the past few decades across a number of areas. So clearly our treatments have gotten better. So new treatments are available. We're getting better at diagnosing, imaging. We're using more precision medicine so that not everybody's treating the same way for a given tumor or cancer. And then we've introduced immunotherapy, which is really sort of the ultimate of personalization of medicine. Clearly, prevention has been a big part of our lives, whether it's interventions for infection-related cancers like HPV-related cervical cancer, or identifying individuals at risk for specific cancers based on their own genetics, like the BRCA1 mutations for breast cancer. These are all relatively recent concepts, and then thinking about novel drug and surgical risk reduction strategies. But more importantly, we've gotten better at getting people through their cancer experience, improving the quality of life during the treatment as much as possible, better management of toxicities. We're using less intensive therapies when possible, and then also integrating palliative care relatively early on in the cancer treatment, which is a relatively novel concept for many of our patients. And then finally, survivorship, which was talked about a little bit before, but clearly as the number of patients that are surviving their cancer continues to grow, the survivorship issues are very real and very relevant, and this is a growing area of research. Early detection of chronic illnesses is really key. So ultimately, what progress amounted to? Well, we currently have somewhere between 14 to 16 million cancer survivors living in the United States today. So survivorship is up, and in the red line you'll see is mortality is down. So if there's any message that's clear that's emerged from the last 20 years, is that survivorship is increasing and mortality is decreasing. And that's not just in the United States. We see this advancement in outcomes, improvement in outcomes worldwide. So it's estimated that currently there are 33 million survivors who are 5-year cancer survivors, and that's a phenomenal and remarkable outcome to highlight. What's even more remarkable is that when you look to see where these individuals are in their post-cancer trajectory, you see the vast majority of these individuals are what we consider very long-term survivors, so more than 5 years out from their cancer. These are individuals where the cancer recurrence rates are going to be increasingly low, and we have new issues that we need to think about as they start traveling in their survivorship journey. So what are we talking about today? We're talking about the health risks associated with treatment that may emerge after the completion of therapy. So many long-term survivors, unfortunately, will develop one or more long-term health problems after their cancer treatment is completed. And many of these conditions are often underappreciated in the general medical community. So if someone leaves the cancer center and goes into the general practitioner's care, they could be one of several hundred patients that they may have. So they may, the primary provider may not know the unique risks that they need to be monitoring for based on treatment exposures. It's important for us to catch preventable problems early so that we can initiate treatment much early on. So why are we talking about cancer survivorship, and why is that relevant to what we're doing? So I want to start off by talking about a patient of mine who I treated as part of my initial training process and training period. She was 17 years old at the time of her diagnosis, and she had been successfully treated for stage 4 lymphoma, which required multiple cycles of combination chemotherapy that included up to 6 drugs given within a 1-week period. And so she successfully completed her therapy. We were able to get her back to school and graduate on time from her high school, and she went off to college, and she went to a different state. And we lost touch with her in part because of school, in part because this is the age where it's very tough to engage individuals after their treatment's done. And she had been complaining of shortness of breath and easy fatigue for several months and had been seen by primary care providers, but had not disclosed that she was a former cancer patient. And many of her symptoms were dismissed until her symptoms got so bad that her parents flew out, brought her back home for an evaluation. And we saw her in clinic. And this is her chest x-ray from when her treatment was completed. So this is just for orientation. This is a completely normal chest x-ray. What you'll see in the middle is the heart. And if you can see the mouse, I'm contouring the outline of the heart. And then there's the black, which is air, which is where air is, which is the lungs. And then these lines are the ribs. So this is a normal chest x-ray, as you would expect it. And so this is what her chest x-ray looked like when we actually saw her in clinic. You see clearly that the heart has enlarged, so it's nearly twice the size as it should be. And instead of having air in the lungs, there's fluid in the lungs. So she had actually developed a relatively rare complication of her treatment called heart failure. This is when the heart is no longer pumping adequately the way it should. And this is a result of high dose chemotherapy that she received for her treatment. It's in the family of drugs called anthracyclines. These drugs have been around for many decades, and they're life-saving, and they're very necessary for the treatment of many of our patients. But clearly we know that there are certain risks associated with it, and potentially early detection and would have prevented this more severe case of heart failure. She eventually went on to get a heart transplantation, and she is alive and doing well. But perhaps if she had been more engaged, or perhaps if her primary providers had been more aware of her health risks, it wouldn't have gotten to the point where she would have developed florid heart failure. So that's really was a wake-up call for me and others in the survivorship community to be more vigilant about educating our patients and empowering them about their needs and their concerns, but also doubling down on research, not just focusing on how to treat cancer better today, but also thinking about how do we treat patients who are beyond the cancer experience in a more comprehensive way, and think about new strategies for prevention and early detection. The cardiovascular disease, which is the broad area of research that I focus on, what are some of the issues that we see? We see issues such as cardiac dysfunction, where, as I mentioned, like with this girl, they can develop, the heart is no longer pumping as adequately as it should, the heart muscles weaken, and the individual can develop heart failure as a worst case scenario. You can have issues with cardiac arrhythmia, so the rhythm of the heart, the rhythm that's really the electrical current that's responsible for helping the heart pump is not working adequately. We typically see those problems in patients who receive radiation to the heart or near the heart or the chest. And we also see premature atherosclerosis, premature coronary artery disease, or heart attacks as a worst case scenario in our patients. Again, we see that more in individuals who receive radiation near the heart or close to the heart. And we also see renal vascular problems, so high blood pressure that can result as a result of certain therapies and surgeries. What do we tell our patients? Well, we tell them it's very important to be engaged in risk-based surveillance, know what your risks are, make sure that they're in our clinics, what we perform as a comprehensive history and physical, where we're monitoring for specific signs and symptoms of cardiovascular disease based on whatever exposures that you may have had. We perform routine echocardiograms, which is an ultrasound of the heart, and the frequency of that really depends on what your risk is. So the high-risk individuals, we perform more frequent echocardiograms, whereas individuals who are low risk may be less. And then we also perform EKGs to look for heart rhythm abnormalities. But more important than anything else, we actually engage and tell our patients that they need to be very vigilant in the management of traditional cardiovascular risk factors like high blood pressure, diabetes, high cholesterol. You'd be surprised how many of our patients have these health conditions and they are not being actively managed. We know now data shows that if these conditions are not managed well, then the risk of cardiovascular problems in our population is much, much greater than what you would expect in the general population. So clearly prevention in the form of better management of blood pressure, diabetes, blood sugar, and cholesterol is the most important step that a survivor can take. And also initiating heart-healthy lifestyle and compliance with the treatment of risk factors. If we want to take it one step further, if patients want to be more proactive, which we encourage all of our patients to be, we encourage them to incorporate exercise, cardiovascular exercise, specifically aerobic exercise where there is elevation of the heart rate. This could be, walking, running, bicycling, anything that's going to get your heart rate up. So not necessarily weightlifting, but the usual cardio exercise that you would think about. So this is a study that was performed in several thousand Hodgkin lymphoma patients. And what you'll see on the bottom on the x-axis shows the intensity of the exercise that they performed. So the more intensive they were involved in exercise during the week, the lower the risk of cardiovascular disease in this population. So the more intensive the exercise, there's almost like a medicine dose-dependent effect, the lower the risk of cardiovascular disease. In fact, you can cut your risk of cardiovascular disease by half if you just follow basic recommendations to do at least 150 minutes of moderate aerobic exercise, walking or running every week, and resistance training every two to three times per week. These are recommendations that many of our survivors are not complying with, and you'd be surprised how much benefit the cardiovascular system and the patient can have if they implement this. So turning our attention to fertility concerns and reproductive health, this is primarily a concern for patients who are adolescents and young adults at the time of their cancer treatment. So what are the issues that we see? For males, the risk of infertility or sterility is primarily due to chemotherapy, and in rare instances, radiation that's delivered to the testes for patients who have acute lymphoblastic leukemia. The chemotherapy agents that we typically see this with are the common ones that are used, including cyclophosphamide, also known as Cytoxan, ifosfamide, melphalan, busulfan, carmustine, and bendamustine. So these are used in many solid tumors as well as many hematologic cancers as well. For females, you actually need a lot higher dose of chemotherapy to damage the ovaries. And typically we see issues with fertility in patients who've received very high doses of alkylating agents, especially in the context of bone marrow transplantation, or individuals who've received radiation to the abdomen and pelvis, including the ovaries themselves. So what do I do as an oncologist for our patients? So if someone is prepubertal and they're male, there aren't too many options, but there are more experimental procedures where we can obtain an immature sperm or testicular tissue for banking. And that's not done routinely, so I'll skip that for now. But for anybody who is post-pubertal and is planning to go through cancer treatment, we strongly encourage them to bank sperm. And there are a number of resources that could facilitate both the cost of banking as well as the maintenance of that long-term, including the Livestrong Foundation. For females, it's a bit of a different story because banking, the concept of banking is not as prevalent, and there are unique issues to that in terms of collection of ovaries and eggs. So as all of you may know, all females are born with a set number of eggs, and once it reaches a certain threshold, so 25,000 or less, a woman will enter premenopause, and then once it's below 1,000, typically somewhere around the late 40s, early 50s, a woman will enter menopause. So there's a normal trajectory of decline over time, and what we think happens during cancer treatment. And this is more of a rare instance, especially in females who receive very high doses of chemotherapy or radiation to the ovaries. There can be a complete depletion of the number of eggs or follicles so that they will enter premenopause immediately after completion of therapy. Thankfully, that's rare. More often than not, we see a change in the trajectory in the depletion of these oocytes or eggs so that individuals may enter perimenopause or menopause at much earlier than what would be expected for the general population. This is important to know. For many patients, it's important for them to understand what their risk is after the completion of therapy, because it could give them a sense as to window in which they actually would either need to bank eggs, or if they are desiring or if they're wanting to have children, to start a family after completion of therapy. So much like males and females, we have established algorithms. Again, it's very difficult to collect egg oocytes from prepubertal females, but there are a number of procedures now that are being piloted in Europe where they can take a tissue, a piece of the ovary, and freeze it and then reimplant that after the therapy is done. That's not standard of care in the United States at this point, but maybe 10, 15 years from now. If someone is post-pubertal and they're able and willing to undergo ovarian stimulation with a partner willing to donate sperm, then we can do embryo banking. But more often than not, what we'll do is we'll actually have the patient undergo oocyte collection. We'll freeze the eggs. We'll collect the eggs, freeze them, and then at a later time through IVF, then they can have reimplantation and induction of a pregnancy. But again, whether or not this is done prior to the start of therapy or after the completion of therapy is a discussion that will be had with the patient as well as the primary oncology provider. It's important to recognize that infertility itself does not produce symptoms. So someone could be completely asymptomatic but not be infertile. The symptoms are really due to gonadal failure of specific hormones like estrogen and testosterone. Infertility may result in significant psychological distress for patient and partner, but it's not typically associated with sexuality. That's a different concern and a very real concern. But we also tell all of our patients that just because they're at high risk of infertility because of the treatments that they had, doesn't mean that they we can exclude unwanted pregnancies. There have been many instances where we've thought someone is infertile, but then they've been able to become pregnant, and vice versa. And the sexually transmitted diseases clearly have nothing to do with the fertility status of the individual. So protection and appropriate sexual practices are clearly important for many of our patients. And then finally, the question that I get asked most is that whether or not the offspring. So if someone has received chemotherapy as in their, let's say, 20s, 30s, will the offspring have an increased risk of cancer or other birth defects many years later if the pregnancy is sired many years later? And the answer is no, as far as we can tell. What do we do for our patients if they're female and they've received specific chemotherapies that put them at risk for infertility? We monitor certain hormone levels, but we also tell them that just because they're menstruating, it doesn't mean that they have adequate oocyte or egg reserve and quality. So there are specific markers that we can look for, as well as ultrasound imaging that we could perform to evaluate what the fertility status of someone is. It's not just about whether or not they're menstruating or not. Many of our patients will have hormonal imbalances, so if they do, it's important for us to then replace their hormone levels, including testosterone, estrogen, and depending on what the other deficits may be. And then clearly referral to a reproductive specialist is key if there's concern for infertility or if pregnancy is desired for someone who is potentially at borderline function. And then I mentioned counseling as well too. So these are some references, and there are many, many references that are available for individuals who are interested in finding out more about this. There are resources that can help individuals with the cost of banking and initiation of fertility preservation. So turning our attention to osteopenia and osteoporosis, which is the weakening of the bones, and this bit, what you'll see on the image is an image of a healthy bone, and then osteoporotic bone is where you see that essentially the strength of the bone has deteriorated over time. This is a normal aging phenomenon. So if you actually look at cross section of individuals in their 80s and 90s, there's a vast proportion of these individuals will have osteoporosis. But for our cancer survivors, we think that osteoporosis is more prevalent at a younger age than what you would expect for the general population. Most of this risk is driven by prolonged exposure to steroids like prednisone and dexamethasone, but there could also be depletion of specific hormones that are important for bone development, including low estrogen level, testosterone, vitamin D, and calcium. We tell individuals that they need to be physically active because physical inactivity is also another strong predictor of who's going to have osteoporosis. So lack of exercise and prolonged bed rest are in fact one of the biggest culprits of who's going to develop osteoporosis. When you look at astronauts, for example, who go into space for many months at a time and they come back, you'll see that a large number of, or the majority of them will have osteoporosis, in part because there is no gravity in space, so they're not able to exercise the way it should, or more importantly, create impact on the bones that can help the remodeling of the bones. So it's really important for individuals to get up and get out of bed as much as possible. How do we screen individuals? Well, we do bone density scans if they're at risk. We look for vitamin D levels and calcium levels, and if low, we can replace them. If there are specific hormone deficiencies, such as estrogen deficiency or testosterone deficiency, or growth hormone deficiency, then they could be replaced to help with bone strength. We reduce the prolonged exposure of steroids. And I mentioned there are also, in addition to calcium and vitamin D, there are other bisphosphonates that are used like Fosamax and other medications that can help with bone rebuilding in individuals who have very significant osteoporosis. What can the patient do and what can the survivor do? Clearly, regular exercise is the most important thing you can do to help prevent osteoporosis and help with bone remodeling and rebuilding. Limit alcohol and smoking intake. Do not smoke, obviously, and then moderate light exposure, because light can give you you can get vitamin D through light exposure as well. Turning our attention to second cancers after completion of therapy. So this is essentially, you have a primary cancer, and then an individual will develop a subsequent cancer 2, 5, 10 years later. It's important to recognize that many cancer patients, when you look at them as a population, they have a high risk of developing a subsequent cancer. Some of this risk is driven by the treatments that they receive, and some of it may be intrinsically genetic. So whatever risk factor that put them at risk for getting, whatever genetic factor put them at risk for getting a primary cancer may put them at risk for getting a subsequent cancer. That we can't control, but what we can control is the treatment-associated cancers. So we counsel and educate our individuals, and we tell them based on their exposures, then there are specific screening and monitoring that needs to happen. So for example, if someone has received radiation to the breast tissue, if female has received radiation to the chest or breast tissue, they have a much higher risk of developing a breast cancer later on. In fact, for a Hodgkin lymphoma patient with Hodgkin lymphoma who's received radiation to the chest, to the breast tissue, to the risk of developing a breast cancer in their 30s and 40s is essentially comparable to someone with a BRCA1 mutation, like the Angelina Jolies of this world. If someone has had graft versus host disease, which is a complication of bone marrow transplantation, then we monitor their mouth and skin for skin cancers and oral cancers. If someone's received radiation to their neck area, typically for head and neck cancers or some types of lymphomas, then there's a higher risk of thyroid cancer. So we examine the thyroid every time, and it should be examined every time they're seen by their oncologist. There's an association, obviously, if they're smokers, then there's a risk of lung cancer, but busulfan at high doses has been associated with lung cancer. And then in rare instances, and certain chemotherapy drugs can result in a leukemia within 2 to 5 years after completion of therapy. If typically this risk in leukemia is limited to the first 2 to 5, in some instances 10 years, but really if within the first 5 years or so you have not developed this, then the risk is very, very low if it's due to chemotherapy. It's important that we screen and pick up these problems much earlier than what you would expect in the general population. But you don't want to do breast cancer screening, for example, in someone, you don't want to wait until they're in their 40s and 50s, especially if they're at risk. You want to think about being more proactive and doing the screenings in their 20s and their 30s if they're at risk. So what can patients do? They can do self-examination, stop smoking, common sense stuff like limiting alcohol intake, and comply with screening recommendations. But it's also important to recognize that so far what we've talked about have been really the issues of physical well-being, functional status, etc. But when you think about the quality of life of survivor, there are 3 very important domains, including the psychological well-being, the spiritual well-being of the individual, as well as the social well-being, which I'll tackle just very briefly. We know that issues with quality of life are complicated, but more importantly, that they're the most frequent subjective complaints in long-term survivors, and these include fatigue, depression, generalized musculoskeletal complaints, and difficulties with concentration and forgetfulness. But less frequently mentioned, but just as important, are problems with sexuality, financial hardship, and social integration, as it was mentioned earlier before I came on the call. This is a study of adolescent and young adults, and essentially shows that what their social functioning was at baseline at the time of their diagnosis, and compares it to the population norms. And what you would expect is that their social functioning, or their sense of social isolation, was much worse than the population norms. And this improves at 12 months after completion of therapy, but at 24 months, it's still not what it should be as part with the rest of the population. So this really gives us a sense as to while they may overcome the medical aspects of their cancer journey, there are clearly psychosocial burdens that can impair normal societal integration for many of our adolescent and young adults. How about fatigue? This is a talk in and of itself that could be given over a 45-minute to an hour-long talk, and I'll essentially say that it's one of the most prevalent symptoms that many of our survivors will have, and clearly it's multifactorial. So cancer-related fatigue could be anywhere from due to pain, anemia, hormonal imbalances, nutritional deficiencies, poor sleep. You'd be surprised how many of our cancer survivors actually have poor sleeping habits that were maybe initiated during their initial hospitalization and disorientation associated with it, but subsequently due to medications and side effects of the treatments that they had. So clearly, when we're tackling fatigue in a cancer patient, we can't think of it as a one solution issue, but it really has to be a multidisciplinary approach in the way we tackle these problems for many of our patients. what do we tell our patients? How do you improve your quality of life after cancer treatment? Well, staying engaged with the healthcare team is key. And I know I'm probably speaking to a very engaged and motivated population of individuals, but recognizing engagement and communication with the healthcare team is really the most important thing that I can stress to you today. It's important for individuals to recognize and be aware of their emotions and recognize that guilt, confusion, and anger, these are all normal processes of the cancer treatment and post-cancer healing process. We also know many of our patients have a new perspective on life and health. Some consider it as a second beginning, and it is really an opportunity for this dialogue to begin with the primary providers and oncology providers and help reorient survivors into this concept of a new beginning and a new start. It's important for individuals to reduce stress through small changes in their life. You'd be surprised how many people will try to go back and reintegrate back and to do all the things that they were doing before their cancer diagnosis, recognizing that saying no may be one of the most helpful things you can do to yourself in terms of no to certain commitments and certain responsibilities. It's imperative that individuals be engaged in exercise, and there are clearly a number of resources, including support groups, social activities, mindfulness, and yoga, that again could be a talk into themselves in terms of how to reduce stress in your life. We tell all our patients to take the time for yourself, for personal reflection, and then clearly keeping a journal or blogging or hobbies are an integral part to thinking about how to process the cancer experience in a more positive way possible. So what do we do? Why is it important for us to continue to be engaged in the survivorship issue? We recognize as healthcare providers that it's not simply about the enumeration of bad events to happen to people. It's the more we study, the more we understand survivorship in our patients, the better we can think about early detection and screening for health problems and prevention. But more importantly, how do we take the lessons learned from our survivors today and apply it towards the new management and the new treatments that were coming up for patients for tomorrow? How do we change practice based on lessons learned from our patients of the past? And that really has been an integral part of mine and other people's research as we think about improving our cancer treatment for our patients. And with that in mind, the Institute of Medicine has made a clear call to action, both to survivors of childhood cancer as well as adult onset cancer. And as part of this call to action, there are very clear recommendations for initiation of risk-based healthcare to monitor for cancer recurrence, surveillance and intervention for late effects, as well as for prevention. And there are well-established evidence-based clinical practice guidelines that can help guide both patients and providers in appropriate long-term follow-up care. There are a number of organizations and a number of resources. Clearly, Triage Cancer is one of them, but I've just put some highlights here and some online resources for both survivors, providers, and family members to peruse. As far as survivorship care plans, there are a number of survivorship care plans that are available, some that you can get on paper. There are apps through the American Cancer Society where you can put in some basic information and get generation of recommendations for surveillance. Needless to say, we are not short on resources. It's a matter of engaging our patients and our survivors. So what can they do? What can survivors do to start the process? It's important to keep a personal health record, as it was mentioned earlier. Ask questions. But these are simple questions that many would not be thinking about unless sort of they are prompted to do so. And I would say the more engaged you are, the more you ask, the better it is for you down the line. So who will be leading my medical care after I finish treatment? That's the most fundamental question that you can ask your oncologist. How do you usually provide survivorship care? Is it that the oncologist is going to do it? Is there a survivorship clinic? Is it the primary care provider? Those are important questions to ask during and after completion of therapy. Are there any survivorship clinics, centers of excellence, or other resources you recommend? How often should I return for a follow-up visit with you, with my family doctor? How many oncologist visits how many a year are necessary, and how many primary care doctor visits are necessary? And then what tests will be needed during the follow-up visit? And then can you provide me a summary of my cancer treatment, as it was alluded to earlier? Your cancer treatment summary has to be, and that's sort of the fundamental, that's the basic resource that can be provided to you once your treatment is done. So I put the ASCOcancer.net, the website's called cancer.net. This is a copy of a sample survivorship plan that you can print out and fill out. But as it was mentioned earlier, there are a number of these resources in which you should have the basics of what was your cancer diagnosis? What stage, if relevant? What surgeries did you have? What chemotherapy did you receive, radiation, and what's the follow-up care plan? How do we personally optimize the survivorship care visit at the City of Hope? Well, we perform a comprehensive history and physical. We have cancer-specific information that we give our patients, and then we actually tell our patients about the specific late complications that are either present or may develop down the line, so they're aware of it, so they can tell us their symptoms before it gets too late. We review all relevant documents prior to the clinic visit, organize the visit according to whether or not someone is a high or low or medium risk individual based on their risk of long-term complications. And then we have a team meeting. Our clinic is based on a medical consultation, but we also use specialized investigations and consultation services, and also use a sort of a team model of multidisciplinary care to help address and counsel our survivors through their journey. And then follow-up is important, that not only do we assess our patients, but also share with them what our findings are. So if we did screening tests, then our patients and the survivors should have that information readily available to them. And then the last few minutes, I'll just talk about the realities of healthcare delivery. And we understand that not all models work for everybody. And the reality is that the healthcare field and healthcare, the delivery dynamic change across the cancer survivorship trajectory. So this is a study that was done in long-term survivors of bone marrow transplantation. And what they were able to show is that the further you get out from your cancer treatment, their medical contact or their interaction with the medical team continues. What happens is that you see a decline in the cancer center visits. So patients are no longer, or survivors are no longer seen in the cancer center visits. Instead, what we're seeing is an increase in the visits with the general practitioners. So us as oncologists, we have to be very much aware that the primary care physicians are increasingly providing the care for cancer survivors, and a cancer survivor may be 1 in 100 or 1 in several hundred in a large practice. So it's important for the patients themselves to be very engaged in what their needs are and express those concerns as well. This is all on the backdrop of emerging paradigms and changing paradigms in healthcare delivery. We're moving away from the traditional paternalistic model of care where the power is essentially all in the physician or the primary provider, where the patient is less empowered. We're moving away from a model where patients are completely reliant on the healthcare team to receive information, diagnosis, and referral. This could be very difficult for patients to navigate, especially when we're talking about multiple physicians and multiple specialists. And interventions are usually in response to physical evidence from the patient. So the patient has to come to clinic for you to be able to diagnose a problem or pick up a problem before it gets and we're moving away from that, and the healthcare field really mandates this sense of an empowered patient sharing ownership, where the power is divided equally between the patient and the physician. But this really depends on the patient picking up the mantle and picking up that sense of empowerment, which is really important. We're thinking about, at this point, patients are becoming informed whenever, wherever, using their interoperable medical records. We're seeing increasingly this co-creation of care packages, survivor care plans, and then more importantly, rapid access to services. And people are increasingly demanding technology-enabled support and self-management. And this really brings up this notion that we really can't rely on the cancer centers to see cancer survivors lifelong, that we really need to be engaged, not just in the primary care, but also think about novel ways in which to screen and monitor for long-term issues associated with their treatment. So are we ready for this? Well, this is a survey from 2014 and 15. If you ask healthcare providers, 81% will say that mobile access to medical information helps coordinate patient care. A lot of them use email to stay connected with their chronic disease patients, and the majority would rather provide a portion of their care virtually, which is important. And in a world where Aetna and CVS are merging, and then access to care is going to be at the tip of your fingertips, but maybe the cancer center is not going to be as accessible moving forward, we have to think about innovative ways to communicate with the primary team, the primary oncology team. More importantly, innovative ways in which patients, and in this case we call it consumers, will think about sort of novel strategies with which to share their well-being and their health state with their providers, whether it be computer-based, app-based, or through other emerging e-platforms for many of our patients. So ending here, what do we encourage our patients to do? I'm hoping that I reiterated the message that it's very, very important for individuals to learn about the treatment that they receive, to get regular checkups focusing on the health risks related to their cancer treatment, whether that checkup is being done at the cancer center, in a primary care setting, or in another setting, has to be in discussion with the primary oncology team and focusing on where they are in their cancer survivor trajectory. Work with healthcare providers to develop a long-term follow-up plan so that when they are no longer being seen in the cancer center, that there is a plan in place for what kinds of screenings are necessary lifelong. And then clearly make healthy choices, recognizing that patients themselves, they are the most important member of the healthcare team, and the more empowered they are, the more engaged they are in what their care needs are in the future, the better the outcome, long-term outcome is going to be. So with that, I'm going to end here, and thank you for your attention and the opportunity to share with you a little bit of this, and maybe if we have a few minutes, I'll be happy to take some questions.
Thank you, Dr. Armenian. We do have a few minutes here. I've been looking and I don't see any questions that come in other than people wanting to get access to these slides. So we'll discuss that after the webinar. And if we can, we'll email these out to the attendees. So ending here, I just want to say thank you from Triage Cancer. And if you want to get in touch with us, you certainly can. You can email us at info@triagecancer.org, sign up for our newsletter on our website, connect with us on social media at Triage Cancer, pretty much it's at Triage Cancer everywhere. And that concludes today's webinar. And again, you will be receiving an email at the end of this to fill out a survey. Thank you very much.